All right, diving deep today into surgery and trauma care. We've got notes, a chapter from a medical textbook, and a mission, right? To give you guys the knowledge you need to navigate this really complex field. Think of this deep dive like we're your guides through this world.
Absolutely, yeah. It's fascinating stuff, really, and we'll cover a lot. I mean, everything from patient history and pre-op evaluations to risk assessments and even post-op complications. So,
So much to unpack, but let's start at the very beginning.
right.
Even before any scalpel is involved, we need the patient's history. I mean, imagine you're the surgeon. What's the first thing you need?
Well, it's like a puzzle, right? You need all the pieces.
Yep.
A thorough patient history is the foundation. It really is. And luckily, we have this handy mnemonic to help us remember the essentials. It's called AMPLE.
AMPL. Okay, tell me more. What does that stand for?
So AMPLE stands for allergies, medications, past medical history, last meal, and then events preceding the emergency. Each one of these is a clue.
Yeah.
They can reveal critical information that can, impact surgical decisions.
Oh, so it's not just about, did they have a bagel for breakfast or something?
Yeah.
It's really about understanding their medical past,
Right.
drug interactions and what even led them to this moment.
Exactly. You got it. And then there's another mnemonic that's super important, especially when we talk about medications, and it's DRO-GS.
Okay, another mnemonic, you've got my attention. What does DRO-GS stand for?
Okay, DRO-GS stands for dispensed, recreational, user, gynecologic, and sensitivity. This one's important because it reminds us to really dig deeper into medication history, like even herbal supplements and things like that. Even seemingly harmless substances can cause problems during surgery, like affect blood clotting or reactions to anesthesia.
It's like a pre-op checklist for potential complications,
Yeah.
making sure we're not overlooking anything.
Okay.
Okay, so once we have that comprehensive patient history, what happens next?
The preoperative evaluation. This is where we go from gathering information to making decisions. We determine which tests are necessary versus, those routine ones, tailoring the approach to the individual patient.
So it's not like a one-size-fits-all situation. Not everyone needs every test.
Exactly. For a healthy person going through, say, a low-risk elective procedure, routine lab testing might not even be necessary. The history and physical exam really provide a wealth of information in those cases. But for others, certain markers are really vital.
Like what kind of markers?
Well, blood count, for instance, that's crucial if there are signs of anemia, for example. Creatinine levels, which reflect kidney function, are a must if the patient might receive medications during surgery that could impact the kidneys. And blood glucose levels are key for specific procedures, especially for individuals with diabetes.
That's like a personalized roadmap, guiding the entire pre-op process based on the individual's risk factors and the specific procedure that's being performed. So now let's talk about something that's probably on everyone's mind, post-operative complications. How do doctors assess that risk beforehand?
Well, it's all about prediction and prevention, right? We've got tools to help identify patients who are at a higher risk for complications. One of those tools is the Detsky's Modified Cardiac Risk Index.
Yeah, I've heard of that one. It's like a point system, right?
Yep, that's it. It assigns points based on things like age, history of heart issues, even things like ankle swelling, which can be a sign of heart problems. More points, higher the risk of cardiac complications. This helps us categorize patients as low, intermediate, or high risk.
So higher points basically mean closer monitoring and maybe even additional interventions, right? To minimize those risks. Are there other systems that doctors use?
Of course. The Lee's Revised Cardiac Risk Index is another really important one. It considers factors like congestive heart failure and diabetes, highlighting, how interconnected our health really is.
Right, it's all about connecting the dots, seeing the big picture. So now, before we even get to the OR, there's anesthesia, and that comes with its own considerations too, right?
Definitely. Anesthesia is a critical part of surgery, and anesthesiologists have their own tools for assessing and managing risk. The ASA classification, for example, helps them understand a patient's overall health status before surgery.
So is that about predicting risk? Like, who's more likely to have a bad reaction to anesthesia?
It's not exactly predicting risk, no. It's more about categorizing patients based on how severe any systemic diseases they have are. This helps anesthesiologists tailor their approach, choosing the most appropriate anesthetic agents and techniques for each individual patient.
So personalized medicine again, basically, right?
Yeah.
Making sure that the anesthesia plan is as safe and effective as possible. What about airway safety during surgery? I mean, I imagine that's a top priority.
It is, of course. And we've got tools for that, too. The Mallampati scoring system, for instance, helps us predict how difficult intubation might be. It's really amazing how much we can learn just by looking at, the anatomy of a patient's mouth.
Wow, that's incredible. It's a special skill to be able to predict those airway challenges just by looking.
So after surgery, there's always that concern about deep vein thrombosis or DVT. How do doctors assess and manage that risk?
Well, we use the modified Caprini risk assessment model. It stratifies the risk of DVT based on, well, things like age, type of surgery, and even pregnancy. This helps tailor preventative measures, which can range from early ambulation to medication or even mechanical methods like compression stockings.
So not a one-size-fits-all approach again, right?
Yep.
Prevention strategies are really individualized based on those risk factors. That makes a lot of sense. Now let's talk about something that might seem a little out of place, food.
You're bringing up a really important point. Surgical nutrition is absolutely crucial for healing and recovery. It's often overlooked, but it plays a huge role in how well a patient bounces back after surgery.
I bet. So how do doctors make sure patients are getting the nutrition they need, especially when eating is probably the last thing on their minds? The American Society of Parenteral and Enteral Nutrition, ASPEN, has developed these guidelines to ensure patients get enough calories and nutrients. The goal is always to meet those needs through the gut whenever possible, but sometimes intravenous feeding becomes necessary.
So it's either feeding through the gut or bypassing the digestive system entirely and going right to the bloodstream. I imagine careful monitoring is key in both cases, right?
Absolutely. We've got to make sure patients are getting the nutrients they need without any complications. Now let's shift gears a bit and talk about trauma care. It feels like a completely different world.
It does. Everything seems so much more urgent and intense.
It is, definitely. In trauma care, rapid assessment and intervention are key. We follow the ABCs,
Mm.
airway, breathing, circulation,
Right.
prioritizing those essential functions first and
Right,
foremost.
those are the essentials of life. You can't really do much else if those aren't functioning properly.
Exactly. And then we utilize tools like the Glasgow Coma Scale to evaluate a patient's level of consciousness. It's a quick way to assess their neurological status and guide further management.
And then the search for hidden injuries, right? It's like a detective looking for clues.
Precisely. We do this systematic head-to-toe examination called the secondary survey, meticulously hunting for any injuries we might have missed initially.
Now, trauma can take many forms, right? From chest injuries to burns. How do the approaches differ?
Yeah, each type of trauma has its unique challenges and management strategies. With penetrating abdominal trauma, for instance, we might use the FAST exam, which stands for Focused Assessment with Sonography for Trauma.
I remember reading about that. It's incredible how ultrasound can be used in such a dynamic setting.
It is. It allows us to quickly check for internal bleeding in the abdomen, helping us make rapid decisions about, whether surgery is needed. And with head injuries, understanding things like epidural and subdural hematomas becomes crucial.
So location and type of bleed really matter. What about burns? These seem particularly complex.
They are definitely. We categorize burns by degree, reflecting the depth of tissue damage, right? And the rule of nines helps us estimate the percentage of body surface area affected, which is crucial for determining treatment and prognosis.
Wow, it's incredible how much goes into managing these different types of trauma.
Yeah.
It's clear that trauma care demands a very specialized skill set.
Absolutely. Requires quick thinking, decisive action, and, a deep understanding of anatomy, physiology, and the principles of resuscitation. It's a challenging but incredibly rewarding field.
Yeah, it really is. As you can see, there's so many factors to consider, from the initial assessment to this specific type of trauma. And
Speaking of assessments, I kind of want to go back to those pre-op evaluations for a sec. You mentioned, not every test is necessary for every patient. So how do surgeons decide which ones are, truly necessary versus routine? That's a great question, and it's one that often sparks a lot of discussion, in the medical community. There's no easy answer really, because it really depends on the individual patient, and the specific surgery being performed.
so it's about weighing those risks and benefits carefully, like taking into account the patient's overall health, the urgency of the situation and potential complications.
Yeah, precisely. Take routine preoperative chest X-rays, for instance. There's actually limited evidence to support their use in patients, without significant risk factors.
So for a healthy individual undergoing a low-risk procedure, a chest X-ray might not actually provide much useful information. But what about someone with, say, a history of lung disease or a smoker?
Well, in those cases, a chest X-ray becomes much more important. It can reveal underlying issues that could impact the surgical plan or the patient's recovery later on.
So it's all about individualizing the approach, making sure those tests we're ordering are actually providing valuable information.
What about other diagnostic tools like electrocardiograms or EKGs? Are those routinely ordered before surgery?
The American College of Physicians recommends preoperative EKGs for patients over 40 years of age, especially if they're undergoing, higher risk procedures. This is because age is a significant risk factor for cardiac complications.
Yeah, that makes a lot of sense. An EKG can provide like valuable information about the heart's electrical activity,
Yeah.
potentially revealing, any underlying issues that need to be addressed before surgery.
Exactly. And for patients with respiratory symptoms or a history of lung disease, spirometry might be ordered to assess lung function. This helps determine if their breathing capacity is adequate for the surgery and the recovery period. It's like building a safety net, making sure that all systems are go before proceeding with surgery. So now I want to circle back to something we touched on earlier, DVT prophylaxis. You mentioned the modified Caprini risk assessment model. But can we break that down a bit more? What kinds of factors contribute to a higher DVT risk?
Well, think of a DVT as a blood clot forming in a deep vein, often in the legs. Anything that increases blood stasis or slows down blood flow elevates that risk.
Okay, so immobility would be a major factor, right?
Yeah.
Like after surgery when patients are often on bed rest.
You got it. That's why we encourage patients to, get moving as soon as possible after surgery. Prolonged bed rest it's a recipe for DVT, basically.
And what about other factors besides immobility?
Age is a big one. As we get older, our blood just naturally tends to clot more easily. Certain medical conditions like, cancer, heart failure, and previous DVTs also increase the risk. And of course, surgery itself. The longer and more invasive the surgery, the higher that DVT risk is.
So major abdominal surgery would be higher risk than, say, a minor outpatient procedure.
Precisely. And even the type of anesthesia used, can impact that DVT risk. General anesthesia, where the patient's, completely unconscious, tends to carry a higher risk than regional anesthesia, where only a specific part of the body is numbed.
Wow, there's so much to consider.
Yeah.
So once the risk is assessed using that Caprini score, how do you actually go about preventing DVT?
Well, that's where prophylaxis comes in. For low-risk patients, early emulation might be enough. But as the risk increases, we might recommend things like graduated compression stockings, pneumatic compression devices, or even blood thinners like heparin or enoxaparin.
Oh, right. Those are the medications I often hear about, in hospital settings. So it sounds like there's a whole arsenal of tools to combat DVT.
There is, yeah. And it's crucial to, use them appropriately, tailoring that approach to each patient's, individual risk profile. And let's delve a bit deeper into the different types of DVT prophylaxis.
Okay, let's dive in.
So unfractionated heparin, for instance, it's a commonly used blood thinner. It's typically given intravenously, and the dosage needs, careful adjustment based on the patient's weight and kidney function.
Oh, so regular blood tests to monitor clotting times would be important then.
Absolutely. We want to make sure that dose is therapeutic, preventing those clots without causing too much bleeding. Another option is low molecular weight heparin, or LMWH.
Like enoxaparin, right? I've heard of that one.
Yes, enoxaparin is a good example of an LMWH. It's given subcutaneously, meaning, injection under the skin. It's often preferred over unfractionated heparin because it's easier to administer, doesn't require as much monitoring, and has a lower risk of certain complications.
It sounds like LMWH is a more convenient and potentially safer option for many patients.
Yeah, in many cases, yes. However, there are instances where unfractionated heparin might be preferred,
Yeah.
like for patients with, severe kidney impairment.
Right, makes sense. It's all about choosing the right tool for the job, right?
Mhm.
Considering the individual patient's needs. So what about those mechanical methods of DVT prophylaxis we mentioned earlier? How do those work?
Well, graduated compression stockings, or GCS, they apply pressure to the legs, promoting blood flow and reducing that stasis.
Yeah.
They're often the first line of defense for low risk patients.
Oh yeah, I've seen those. They're like really tight socks.
Yeah, they are. And they need to be worn properly, of course, to be effective. Another mechanical method is pneumatic compression devices, or PCDs.
Those sound more high tech.
They are. They're essentially like sleeves or boots that inflate and deflate, mimicking the muscle contractions that, naturally happen when you're walking. This rhythmic squeezing helps push blood through the veins, preventing clots from forming.
So even when a patient's immobile, these devices can like simulate movement and promote circulation.
Exactly. They're often used, in conjunction with medication or for patients who can't tolerate blood thinners.
It's amazing how much technology has advanced in this field, giving us like so many options for DVT prevention.
Yeah, it really is. It's a testament to, the ongoing research and innovation in medicine,
Yeah.
always striving to improve patient care and outcomes, right? Now, what about those really high-risk patients where even medication and mechanical methods might not be enough? Are there any other options?
Yeah, that's a great question. What else is like in the arsenal?
Well, in certain cases, we might consider a greenfield filter. It's a small cage-like device that's inserted into the inferior vena cava, the large vein that carries blood back to the heart from the lower body.
So it acts like a trap, basically, right?
Like,
Catching any clots that break loose from the legs before they can, travel to the lungs and cause a pulmonary embolism.
precisely. It's a more invasive procedure though. So it's reserved for those at very high risk or those who can't tolerate other forms of prophylaxis.
It's fascinating how there's this whole spectrum of preventative measures, each tailored to the individual's specific needs.
Yeah, that's the essence of personalized medicine, right? Finding the right balance between risk and benefit for each patient.
All about minimizing complications and maximizing recovery. So let's shift gears again back to the world of trauma.
All right, let's get back into it. So when we're facing a trauma patient, remember the first and most crucial step is assessing the ABCs: airway, breathing, and circulation.
Right, right. Those are like the fundamentals of any emergency situation, really.
Yeah.
You can't do much else if those aren't functioning properly.
Absolutely. If the airway is compromised, immediate actions needed to establish a patent airway. This might involve simple maneuvers like chin lift or jaw thrust or more advanced techniques like intubation.
Right, intubation. That's where a tube is inserted into the trachea to help the patient breathe.
That's right. It's a critical intervention in cases of, severe airway obstruction or respiratory distress.
And what about breathing? How do you assess that?
Well, we look for signs of adequate ventilation, like chest rise and fall, listening for breath sounds and checking the patient's, oxygen saturation. If breathing is compromised, we might need to provide, supplemental oxygen or even mechanical ventilation.
In circulation, what are the key indicators there?
Yeah. Well, pulse rate and blood pressure are the most obvious signs. We also assess, skin color and temperature, capillary refill time, and mental status, right? A rapid, weak pulse, low blood pressure, pale and cool skin. These are all signs of compromised circulation.
It sounds like a very rapid assessment, looking for those telltale signs and reacting quickly.
Exactly. In trauma, time is of the essence.
Yeah.
We need to identify and address life-threatening issues like immediately.
It's all about prioritizing and stabilizing the patient. So once those immediate concerns are addressed, what comes next?
Well, then we move on to the secondary survey, a more detailed head-to-toe examination, basically to uncover any hidden injuries that might have been missed during that initial assessment.
So it's like a deeper dive, looking for those less obvious but potentially serious injuries.
Precisely. We carefully examine, the head, neck, chest, abdomen, pelvis, and extremities, looking for any signs of, fractures, dislocations, internal bleeding, or nerve damage.
And I imagine imaging studies like X-rays and CT scans become really invaluable at this point.
Absolutely. They help us visualize, those internal structures and identify any hidden injuries that might not be apparent, just on physical exam alone.
So it's like putting together a puzzle, piecing together all the information to get that complete picture of the patient's injuries.
Exactly. And based on the findings of that secondary survey, we can then, formulate a definitive treatment plan.
So the initial assessment is all about stabilizing the patient, while the secondary survey is about identifying the full extent of their injuries.
That's a great way to put it, yeah. Now let's delve into some specific trauma scenarios, starting with chest trauma.
Okay, what are some of the most common types of chest injuries you encounter in trauma situations?
Well, rib fractures are very common, especially in blunt force trauma, like falls or motor vehicle accidents. They can be quite painful, but most heal on their own with just conservative management.
Conservative management meaning like pain control and rest.
Exactly. However, multiple rib fractures can lead to what we call a flail chest. That's
Huh.
where a segment of the rib cage, breaks free and moves paradoxically during breathing.
Paradoxically, what does that mean?
It means that the flail segment moves inward during inhalation and outward during exhalation, the opposite of normal chest movement.
Hmm.
And this can severely impair breathing, and it requires immediate medical attention.
Oh, wow, that sounds serious.
Yeah.
What about other chest injuries besides rib fractures?
Well, pneumothorax or a collapsed lung is another common chest injury. It occurs when air leaks into the pleural space, that space between the lung and the chest wall, causing the lung to
And
collapse.
what causes that air leak?
Well, it can be caused by blunt force trauma, that ruptures the lung tissue, or by penetrating trauma like a stab wound or a gunshot.
So in a pneumothorax, the lung is essentially like deflated, impairing breathing.
Exactly. And the severity of a pneumothorax can range from, mild, where only a small portion of the lung collapses, to massive, where the entire lung collapses, leading to severe respiratory distress.
And how is a pneumothorax treated?
Small pneumothoraces, they might resolve on their own, but larger ones typically require a procedure called a chest tube insertion. This involves placing a tube into the pleural space to drain the air and allow that lung to re-expand.
So the chest tube acts like a vacuum, basically,
Yeah.
sucking out the air and restoring negative pressure in the pleural space.
That's a good analogy, yeah. Now let's talk about another potentially life-threatening chest injury, hemothorax.
Pneumothorax, that sounds like blood in the chest cavity.
You're exactly right. Hemothorax occurs when blood accumulates in that pleural space, often due to bleeding from the lung itself, or from blood vessels in the chest wall.
So it's similar to a pneumothorax, except instead of air, it's blood that's compressing the lung.
Precisely. And just like pneumothorax, the severity of a hemothorax can vary. Small hemothoraces might be managed conservatively with observation and blood transfusions, while larger ones often require surgery to stop the bleeding and drain the blood.
So it sounds like chest trauma can range from, relatively minor rib fractures to life-threatening conditions like tension pneumothorax and hemothorax.
That's right. The key is to, quickly assess the severity of that injury and initiate the appropriate treatment.
So now what about abdominal trauma? That seems particularly complex given, all the vital organs located in the abdomen.
Yeah, you're right. Abdominal trauma can be quite challenging. It can involve injuries to the liver, spleen, kidneys, intestines, and major blood vessels.
So how do you even begin to assess like abdominal trauma? It seems like there's so much to consider.
You're right. It can feel like navigating a minefield. The first step is always to consider the mechanism of injury.
Yeah.
Was it blunt force trauma like a car accident, or penetrating trauma like a stab wound? This helps us, anticipate the potential injuries.
So a punch to the stomach versus a stabbing, would raise different concerns.
Exactly. Location is key too. If someone's stabbed in the upper right abdomen, you'd immediately be worried about liver injury, right?
Yeah.
We then, do a thorough physical exam, looking for signs of tenderness, distension, guarding, and bruising.
I imagine imaging studies would be like crucial for confirming the diagnosis and seeing the extent of those injuries, right?
Absolutely. While diagnostic peritoneal lavage, or DPL, that's where you insert a needle to aspirate fluid.
Mhm.
That used to be the gold standard. It's largely been replaced by the FAST exam these days.
Right. That's the focused assessment with sonography for trauma. We talked about that earlier in the context of abdominal bleeding.
Yes. AFAS uses ultrasound to quickly check for free fluid in the abdomen, which is a strong indicator of internal bleeding. It's fast, accurate, and can be done right at the bedside.
It's amazing how ultrasound has like revolutionized trauma care, allowing for such quick and relatively non-invasive assessments. Now let's move on to head injuries. Those seem particularly concerning given how delicate the brain is.
They are, definitely. Head injuries are a leading cause of death and disability worldwide, ranging from, mild concussions to severe traumatic brain injuries, or TBIs.
Yeah, concussions often get a lot of attention, especially in sports these days. How are they different from from those more severe TBIs?
Well, concussions are temporary disruptions in brain function,
Mm.
often causing, symptoms like headache, dizziness, and confusion. Think of it as a temporary shaking up of the brain. Most resolve on their own with rest and observation, but repeated concussions can have, long-term
Well,
consequences.
that's why it's so important to take even seemingly mild concussions seriously. But with TBIs, we're talking about like actual structural damage to the brain.
Exactly. And those can have a wide range of devastating effects, from cognitive impairment and personality changes to physical disabilities. The most common types include, skull fractures, contusions, which are basically bruises on the brain, and hematomas.
Hematoma, that sounds dangerous.
It can be. Hematomas are collections of blood within the skull, and there are different types: epidural, subdural, and intracerebral. Epidural hematomas occur between the skull and the duramater, that tough outer layer of the brain. Subdural hematomas occur between the duramater and the arachnoid mater, another layer. And intracerebral hematomas occur within the brain tissue itself.
So the location of the bleeding within the skull really matters. What
Yeah.
makes these hematomas so dangerous?
Well, they can compress the brain, leading to increased pressure within the skull, what we call intracranial pressure, or ICP. And an elevated ICP can damage brain tissue and even be fatal if not treated promptly.
So monitoring for signs of increased ICP is crucial in head injury cases. How are head injuries typically managed?
It really depends on the severity. Mild TBIs like concussions are usually managed with rest and observation, making sure those symptoms improve. More severe TBIs often require hospitalization and close monitoring of vital signs and neurological status.
And I imagine surgery might be necessary in some cases.
Yeah, yeah. If there are large hematomas or skull fractures,
Mhm.
pressing on the brain, surgery might be performed to remove the blood clot or repair the fracture. It's amazing what neurosurgeons can do, operating on such a delicate and complex organ.
It truly is. So we've talked about chest trauma, abdominal trauma, and head injuries. What about burns? They seem like a completely different category of trauma.
You're right. Burns are unique. They involve damage to the skin, which is the body's largest organ, and plays such a vital role in protection and temperature regulation.
And the severity of a burn depends on the depth and extent of the damage,
Yeah.
right?
Exactly. Burns are classified into 4 degrees based on, how deep that tissue destruction goes. First degree burns involve only the epidermis, that outermost layer of skin. Think of like a mild sunburn. Second degree burns extend into the dermis, the layer beneath the epidermis, and typically involve blisters. Third degree burns go through the full thickness of the skin, destroying both the epidermis and the
Yeah,
dermis.
those sound incredibly painful.
They can be, yeah. But interestingly, third degree burns often aren't as painful as second degree burns because the nerve endings are actually destroyed. Fourth degree burns extend beyond the skin into underlying tissues like muscle, bone, and tendons. They're the most severe.
So pain isn't always a reliable indicator of burn severity. What about treatment? How do approaches differ based on the degree of the burn?
Well, minor burns like first degree and small second degree burns can often
Yeah.
be treated at home with over-the-counter pain relievers and topical ointments. But more severe burns, especially those covering a large area of the body, often require hospitalization.
And what kind of treatments are used in a hospital setting?
Treatment for severe burns can be quite complex and often involves a multidisciplinary team, really. Fluid resuscitation is crucial, to replace fluids lost through that damaged skin. Pain management is essential, of course, as you can imagine. Wound care is critical to prevent infection, and surgery, often involving, skin grafting, might be necessary to cover those large burned areas.
Right, skin grafting. That's where healthy skin is taken from another part of the body and used to cover the burned area, right?
Exactly. It helps promote healing and reduce the risk of infection and scarring. Now, shifting gears a bit, let's loop back to something we discussed earlier: surgical nutrition.
Right. You mentioned it's crucial for healing and recovery. Can you elaborate on why that is?
Sure. So surgery is incredibly taxing on the body. It triggers a cascade of hormonal and metabolic changes that increase the body's energy and nutrient needs. Think of it as the body, going into overdrive to repair tissues and fight off infection.
So it needs extra fuel, basically, to handle all that repair work.
Exactly. And adequate nutrition helps, support wound healing, maintain a strong immune system, and promote overall recovery.
And what are the key nutrients involved in wound healing?
Protein is essential for building and repairing tissues. Vitamin C and A are important for collagen synthesis, which gives, strength and elasticity to the skin. Zinc is involved in cell growth and immune function. And of course, calories provide the energy to power all these processes.
It's not just about, getting enough calories. It's about getting the right mix of nutrients to support that healing.
Precisely. A balanced diet is crucial for surgical patients, but that's not always possible, right? What about patients who can't eat by mouth? Either because of their condition or the type of surgery they had.
Right. That's a great point. What are the options in those cases?
Well, we might consider enteral nutrition. That's where you deliver liquid nutrition directly into the stomach or small intestine through a tube. This is preferred whenever possible because it helps maintain the gut's integrity. Or if that's not feasible, we might use parenteral nutrition, also known as total parenteral nutrition, or TPN.
So with enteral nutrition, you're still using the digestive system, just bypassing the mouth. But with parenteral nutrition, you're going straight into the bloodstream.
Exactly. TPN bypasses the digestive system entirely, delivering, nutrients directly into the veins. It's usually reserved for patients who can't tolerate enteral feeding for various reasons.
It's fascinating how we have these options for providing nutrition even when the normal route of eating isn't possible.
It is. It highlights how important nutrition is, in the surgical setting. Now, let's shift gears one last time and talk about some potential challenges that can arise after surgery. We've already discussed, DVT extensively, but what are some other common post-op complications?
Okay, give us the rundown.
Well, infection is always a concern. Surgical wounds are susceptible, especially if the surgery was long or the patient has other health issues. Bleeding can occur, during or after surgery, and that can be a major concern. Pain is an inevitable part of the surgical experience, and we focus a lot on pain management to aid in recovery. Then there are things like ileus. That's a temporary paralysis of the intestines that can happen after surgery.
Ileus. I've never heard of that. What does that involve?
It basically means the intestines aren't moving things along as they should. It can cause, nausea, vomiting, and abdominal distension. It usually resolves on its own, but it can be quite uncomfortable.
So what other complications are common?
Urinary retention. That's where people have difficulty urinating after surgery. That's something we watch for, especially in those who had spinal anesthesia. Pneumonia, an infection of the lungs can happen, particularly in immobile patients. Wound dehiscence, that's where a surgical wound reopens. That's a serious complication. And of course, we've already talked about DVT in detail.
Wow, that's a lot to consider. It's like there's a whole other set of challenges that can arise, after the surgery's over.
There are, yeah, and we're always vigilant in monitoring and managing these potential complications. Early ambulation, good pain control, meticulous wound care, and close monitoring are all key aspects of postoperative care.
It's all about minimizing those risks and promoting, a smooth recovery. Now, before we wrap up, I want to revisit those mnemonics you mentioned earlier. You shared ample E and D drugs for patient history. Any others that are especially useful in surgical care?
Oh, one of my favorites is the 5 Ws for postoperative fever.
Okay, tell me more. I love a good mnemonic. It's like a mental shortcut, for remembering important information.
It is. So the 5 Ws stand for wind, water, wound, walking, and wonder drugs.
Okay, break that down for me. What do those W's represent?
Right. So wind refers to atelectasis. That's where air sacs in the lungs collapse, often due to shallow breathing after surgery. Usually happens, within the first 48 hours. Water points to urinary tract infections or UTIs, which can develop, around 48 to 72 hours after surgery, especially if if a catheter was used. Wound refers to surgical site infections, which can occur anytime, but are most common after 72 hours.
So it's like a timeline of potential causes, starting with lung issues, then moving to urinary tract issues, and finally wound infections.
Exactly. Walking represents deep vein thrombosis, or DVT, which usually occurs, after 72 hours as well. And finally, wonder drugs refers to drug fever, a fever caused by a medication, which can happen at any time, but is more common after a week or more.
This mnemonic is a great tool, for systematically thinking through those potential causes of post-op fevers, like a mental checklist.
It is. It helps, narrow down the possibilities and guide further investigation. Now, as we approach the end of our deep dive, I'm curious, what are your biggest takeaways from this exploration of the surgical world?
Well, I'm really struck by the sheer complexity and intricacy of it all. It's not just about the surgery itself. It's about the meticulous preparation beforehand, the careful management during the procedure, and the comprehensive care afterward, and it's all incredibly individualized, tailored to each patient's unique needs.
You've hit the nail on the head. It's a true team effort involving not just the surgeon, but also anesthesiologists, nurses, pharmacists, physical therapists, and countless other healthcare professionals.
It's really a testament to the dedication and expertise of everyone involved in this field. But we've focused a lot on the technical aspects of surgery today. What about the human side of it all?
Mm-hmm.
That's a great point. We've covered the science and the techniques, but surgery is ultimately about people, the patients who entrust us with their care, and the healthcare professionals who dedicate their lives to this challenging but rewarding field.
It's about compassion, skill, and the constant pursuit of better outcomes, really. And for our listeners, if you're facing surgery yourself or just want to learn more, don't hesitate to talk to your healthcare provider or explore reputable sources of information.
Yeah, knowledge is power, and in matters of health, being informed is always a good thing.
Well said. So until next time, keep exploring, keep learning, and keep diving deep.